A very good evening, everyone, and welcome to another edition of the webinars hosted by the MB Academics. And we have with us Dr. Amandeep Singh today. And it is my pleasure to have you, Dr. Amandeep, with us today. And it's also my pleasure to introduce you to the audience. So Dr. Amandeep Singh is a veteran of the Indian Air Force with service in the aviation medicine and trauma care. And currently he's serving as a consultant AI and healthcare at Tata Medical and Diagnostics, and also the director of the laboratory services at IKIM Health, Bangalore. Dr. Singh, he has done his MD and DNB in biochemistry from AFMC Pune and is currently pursuing his PhD in molecular biology. He has over 17 years of diverse experience spanning molecular diagnostics, AI integrated healthcare delivery, and clinical biochemistry. Dr. Singh has authored many research publications and he continues to mentor postgraduate students as well. His areas of expertise include diagnostic algorithms in diabetes care, biochemistry, endocrinology interface, AI-driven clinical decision and support systems. So we welcome you, Dr. Amandeep, to our this webinar forum, and we are glad that you are with us. Dr. Amandeep would be deliberating on bridging biochemistry and endocrinology, diagnostic dilemmas, and laboratory pearls in the spectrum of diabetes. Over to you, Dr. Amandeep.
Thank you very much, ma'am, for the warm introduction. Thank you very much. I'll be just sharing my screen, ma'am.
Yes, please.
So I think let's begin with today's introduction. I hope my screen is visible to everyone.
Yes.
So let me start with my roadmap to hold this diagnostic data. So what I will be going through in our next 40 minutes will be 3 micro cases, and we'll be cross-examining using the ADA guidelines. And then I'll introduce you to the lab framework, which I have been using and has been really helpful in detecting various errors and even missing the diagnosis. Just a couple of, a few words will be future leap. We'll be just speaking about very minimal about the autoantibody and AI-powered QC dashboards. So let's begin with our first micro case. So we have this 32-year-old professional who was a fitness app addict and whose BMI well maintained with 23, and he was found during his company's annual examination screen of HbA1c 6.8%. And you can see his OGTT values, they are all within very normal range. So what do you think, what should be the next best step? Now here you can see that we have, the discrepancy. The HbA1c is showing diabetic range while the OGTT is normal. What should we do? So you can answer yourself, but for me, what I will do is the repeat HbA1c with HPLC. Now let me introduce here a very important lab pearl. So whenever you find HbA1c, and the glucose, they are in disagreement. So the first most important thing is to rule out the HB variants. It should not be the last, like. So, and there is a criteria which says that more than 15 milligram per deciliter A1C glucose gap, which is equivalent to 0.5% of HbA1c. Now, here I would like to mention that you can calculate EAG from the HbA1c value. The EAG can be calculated for 6.8%, 28.6 multiplied by HbA1c minus 46.7. That will give you EAG value. Normally reports also mention. So whenever you have such a discrepancy, it's always good to go ahead and repeat. Now, what we did in this case, so we did the HPLC, and we reflexed. We have there's something called as reflex testing. That's like if you do the boronate affinity chromatography, that's just a 4-minute you can do. And what you find is, we found this HBD variant. So here you can see the graph. You can see at almost 3.9 minutes, you can find the HBD graph here on the screen. Now, This HBD Punjab, this is a phantom glycator. Now, when I say this, so this HBD Punjab, it causes analytical interference, not due to the glycation, but altered charge property. The substitution which happens in this case. So on an HPLC, if it depends upon what variant you are running. If you are running a HbA1c mode, you will find the peak at around 1.5 minutes, while in a full-blown beta thalassemia program on the BioRad variant 2 panel, you will find it close to 3.9. So what we have to do? So rapid check algorithm is you immediately should look for the gap. How much is the gap? If the gap is more than 15, you run the reflex testing. You repeat it on boronate affinity or enzymatic method, and you confirm. You keep it in mind that when you repeat it, you check your QC values, CV percentage and bias. That should be very particular. What will happen is, the HbA1c may be overestimated due to hemoglobin variant, and then you can take a call. You can even monitor it with the glycated albumin or CGM. The most important thing is to understand this gap. So the key takeaway here is you fix the analytical interference first, and if the variant is confirmed, then you switch to the follow-up using the glycated albumin or the CGM, whatever is comfortable to the patient. Maybe in that case, you can speak to the clinician also. Now, just bringing on this case wherein we cross-examine using the ADA guideline. You can read it here clearly. When a substantial discordance exists between blood glucose A1C, evaluate for analytical interference or use the plasma-derived values instead. So that is a clear-cut take-home message. That's what I wanted to say. Now let's move ahead, and once you confirm the variant, whatever it is, and then you ask for the follow-up, then it's better, you stick on to the OGTT values, or you go ahead with the CGM or the glycated albumin. Let's move on to our next micro case. So here you can see that there is another undefined pattern here. So this is a 45-year-old woman with BMI of 25, diagnosed with type 2 diabetes 4 years ago, and she was already on metformin and on oral DPP-4 inhibitors. Yet you see her fasting plasma glucose value, it is 170, and HbA1c is also 8.5%. The catchy part was she had a history of autoimmune thyroid, and there was her C-peptide was also done, which was showing 0.4. So what should be the next biochemical step? What is, as a biochemist, you should think? What we did, we went ahead with the GAT and islet antigen antibodies. So just this will cost another 1,000 rupees, but years of all this drug escalation, because she was already failing on these drugs. This all can be terminated in one go. So the message here is that a reflex autoantibody panel, especially with the two antibody panel of GAD and IA combined, if these are positive, we're thinking of something, we call it as LADA. So LADA is something that is latent autoimmune diabetes in adults. So just whenever we have autoantibody, even one antibody, so we have three antibody panel, GAD, IA2, and then ZNT8. So if even a single is positive, LADA is confirmed. And also keep in mind the C-peptide values. When we check for the C-peptide, any C-peptide value less than 0.8 nanogram per ml at a glucose which is more than 140, that confirms the poor beta cell reserve. In South Asian population, almost close to 7 to 11% of the adult onset diabetes are actually LADA. That is published in one of the reports. So the practical workflow, any adult, if it is less than 50 years of age, and is if you talk to clinician and he says failing oral therapy, then it's better to go ahead with the antibody testing. And especially in any non-obese person with less than 50 years of age and with history of drug failing, it's always advisable to rule out the antibody, because if you find this antibody positive, the mainstay treatment remains you have to control the basal insulin. So also screen, since she has this TPO history, you can always, based on the personalized history of that patient, you go ahead and rule out, the TPO antibody, even you rule out the thyroid or TSH also and B12, because this is the autoimmune cluster, which is very common. And just 1,000 rupees panel can save years of futile failing therapy. And because it's a spot signature, which as a which will be very good input, that recommending insulin at a very early age. I had my own cousin, he had this similar scenario, and we found, and he was put on insulin. Now he's on remission therapy. So this is how you can control this. Now, when we cross-examine this, you see the section 2.4 of the ADA. So it says adults with apparent type 2 diabetes who are lean and they show rapid deterioration on oral results or have personal or family autoimmune history should be tested for pancreatic autoantibodies. So that is one, very important. As you can see the case, which is well. So in all the three boxes, any person who is lean with the failing of oral therapy, the patient is not responding, still you're getting high values, you can very well go ahead with the antibody testing. And in your LIS comment, you can very well add the clause saying as per ADA 2025 section this, this pattern supports LADA, and GAD and IA2 are recommended, something like that you can very well do. So this is one take home message. Which now just since we talk about LADA, so we have another entity, MODI, that is the maturity onset diabetes. So what are the stark differences? So when we talk about, at first glance, we start with age and family tree. So MODI typically presents before 25, and it shows autosomal dominant. Here the gene testing is very important. While in LADA, it appears usually after 30 years and is usually sporadic. And you see the antibody pattern. And if you are just testing and doing an antibody at first and it comes out to be positive, you are saving, almost close to 40,000 of a patient who will be, unnecessarily undergoing a gene panel, which may not be probably required in this case. So immunological profile, if antibodies are positive in LADA, it is absent in MODI. So, and you look for the history, at least, along with pairing with the C-peptide, along with the three. So, bottom line is pairing a C-peptide with the 3 antibody screen panel before you label any non-obese type 2 diabetes. It will help. It will, give you a lot of clarity what you're dealing with. If you're dealing with LADA, it will help a lot. And especially once you diagnose, especially the various mutants of MODI like HNF1A, they respond very beautifully if you diagnose that to the low dose sulfonylureas, while LADA will require insulin at early stage. So see, the management will change entirely. Just because of your one reflex testing, it can entirely change the clinical picture. So the bottom line message is, don't label any lean, non-obese adult who is already labeled as type 2 without a C-peptide and antibody run. Don't label them as type 2 diabetes. And then let's go ahead with our third case, the silent pancreas. We know this entity, type 3C diabetes. So here's a case that masquerades type 2, but it hides something far deeper. So we have this 55-year-old male with BMI of 24, diagnosed with diabetes, and he had chronic pancreatitis. You can see there's unintentional weight loss also with greasy stools, steatorrhea. The FBG values is like 160, and the HbA1c was shown as 7.2. So the number are pointing already towards the mild diabetes. Now the clinician starts the oral drugs, but they see something is not right. Now what is that something not right? Maybe the person is having some clinical symptom, okay, like what I've told, and there is a mismatch between the diabetes severity and the pancreatic function. So what could we think here in this case is a type 3C pancreatic, which is a pancreatogenic diabetes. Now, most people go wrong here when they rerun the OGTT and they keep checking antibodies from 10 other places. But in chronic pancreatitis, autoimmunity is rarely the cause. Okay, so what the real test that that can crack that case? What you should go? So what what is recommended is they say fecal elastase with in combination with C-peptide levels. So here we have a classical, whenever the fecal elastase you do, the values is coming, less than 200 microgram per gram, it confirms exocrine insufficiency in a patient. And also when we combine the C-peptide, if the level is less than 0.8 at where we are having, glucose of more than 140, it is pointing clearly towards the beta cell depletion. So in this patient, the fecal elastase came to around 85 and the C-peptide was found 0.5, which clearly sealed the diagnosis of type 3C. So when we talk about pancreatogenic diabetes, we need to be very clear that what cracked the case. So fecal elastase is one, reflex test which should come in your mind in that case that you should order. And why? Because 4 to 9% of all diabetes, it may be hidden somewhere, and insulin need is high. Hence, the episodes of hypoglycemia and ketoacidosis will also vary. So because, and also keeping in mind, if we are keeping the treatment and management part here, in this case the clinician will put him on the PERT therapy, which is close to 40,000 units of lipase per meal, and then the basal insulin, with the oral hypoglycemics, often fail due to impaired absorption and dual hormone deficiency, so we have to start the insulin. And also we can screen, simultaneously the fat soluble vitamins and bone health also. So the action algorithm which we need to put in place is whenever we have glucose dysregulation, along with we were having some history or anything of pancreas origin, it's better to order fecal elastase. And when we go ahead and cross-examine with the ADA guidelines, it clearly says that hyperglycemia with chronic pancreatitis, pancreatic classification, pancreatectomy or cystic fibrosis should be classified as type 3 and managed with early insulin plus exocrine enzyme replacement when fecal elastase level is less than 200 microgram per gram. So in our patient, it clearly shows, I have put the timeline. So most important thing is that under, if it is under 200, it confirms the diagnosis, and you can always paste this clause in your whenever you are reporting. Now moving ahead with another spectrum, gestational diabetes. We always talk, few days back also in our group we found a lot of query about this also. So gestational diabetes is where one miss minute by minute. 1 milligram can change your diagnosis and the consequences also. So what is our role as biochemists? First the load, the 75 gram OGTT test has to be consumed within 5 minutes. That is most important. And if it is slowly sipped or diluted over time, and the 1 hour value can drop from 185 to 170, which is enough to miss a diagnosis, I guess. And the second is the decay of the room temperature. So at room temperature, the plasma glucose drops by 2 to 3 milligram per deciliter per hour in fluoride tubes. So this can easily lead to underdiagnosis. So ADA recommends citrate buffer tubes, which are 23% better, they say, and the decay is less than 1 milligram per deciliter per hour as per the ADA, and it recommends that if your the sample collection to analysis time is beyond 30 minutes, you're not centrifuging within 30 minutes, it's better to use the citrate tubes. That is the gold standard ADA. That is what they say. Also, it recommends the single step 75 gram OGTT between 24 to 28 weeks, and diagnosis is made even if one of these cutoff is met. That you are all well aware that fasting, more than equal to 92, 1 hour more than equal to 180, and 2 hour more than equal to 153. So the critical pre-analytical workflow here is centrifuge within 30 minutes. If the analyzer is delayed, it's better to store the sample on ice. That's what is important. And yes, pre-label the time tubes to avoid mix-up during phlebotomy. It's better you label them that this was taken at this time. Otherwise, what will happen is you will never get to know which was for 1 hour. The phlebotomist have to be trained on that. And especially we are well aware that HbA1c is unreliable. It's better to because of the hemodilution and RBC lifespan. Instead, glycated albumin, whose reference range is is 11 to 16% for diagnostic. That is what is recommended. And then the most important take-home message here is lab speed is the diagnostic power here in this pregnancy when we deal with gestation. Now, quickly, I'll speak about what are the pediatric pearls when we deal with the diabetes diagnostic. So, first of all, the HbA1c, it is unreliable because of the RBC, shorter RBC lifespan in pediatric age group. And, it can be falsely low by 0.3 to 0.5%, which means close to 9 to 15 milligram underestimation, okay, of EAG. And we need to always cross check with the fasting glucose or OGTT. And the second is the antibody behavior. And now in adults we talk about, we can do, even if we do the 2 antibody panel of GAD plus IA2, it will give you 92% sensitivity, while in pediatric Z and T8 alone can give up to 60 to 65% of type 1 cases, which is positive. And third thing, if antibodies are negative, but you still have a strong family history, you should always think of MODI in that case. Why? Because I told you MODI criteria less than 25, diabetes in at least 2 generations, okay, and the slim built and negative antibody. If we have these 3 criteria in place, it's always go ahead with the gene panel. See, remember, the pediatric diabetes is not equal to the small adult diabetes. Their biochemical changes with the age. So, and the fourth thing is the C-peptide level, which will help in tracking the honeymoon phase. So, if C-peptide falls below 0.6, the child will likely need full insulin coverage. And if it is more than 1, you may still be in, you think like it may be in partial remission. So, in every child's biochemistry should be interpreted age-wise and not size-wise. And get the right antibody at right time, and go ahead with the gene panel if it is required. We move ahead. Now when we talk about all these cases, we see there is a transition pattern. Okay, so pattern 1, like we spoke about, mismatch with the HbA1c and glucose. Then we talk about, a lean and drug failure with low C-peptide level, and then we talked about the exocrine collapse in pancreatic disease with weight loss and with low fecal elastase. So you remember the pattern that is very important is that the glycation is not equal to glucose. If you have doubt, check for variant. If there is rapid OID failure, there is a lean person you are dealing, think of LADA, and if it is pancreatic involvement, think of type 3C. Means all the patterns, they prompt to some reflex testing, and they will definitely guide to the precise therapy. Now, based on this, now I introduce the lab detect framework. So each alphabet of this lab detect I will be speaking. So let me introduce you L for linearity, A for antibody, and I'll go ahead and explain each one of them, how you can put this framework in your lab, and that will help you, missing any errors and even missing any diagnosis with the, kind of reflex pattern which you can activate at your end itself. So the most important thing when we talk about the clues is the linearity and the error. So every lab professional knows that linearity is a part of validation. But diabetes, when it comes to diabetes diagnostic, linearity, it saves life. So, how you can do it quickly. So you can always take, the 5 calibrator level across the reportable range, say from 20 to 600. And you run the duplicates, calculate the mean, and plot it against the against expected values. So if the deviation is more than 10%, then it's a red flag. Especially near the extremes. For example, a sample with real glucose of 660 may be measured as 590 probably on a linearity failing analyzer. So the case may be undertreated, I guess. And if you check the line, the curve, it should be straight line always. That's always we have learnt in our PG days also. So you can run this calibration curve, and don't forget that there are immunoassays like prolactin and insulin, for whose anything above 1000 microliter, that can trigger the hook effect also, especially in prolactin, wherein we can falsely label macroadenoma as mild, right? So most important thing is a single point calibration may look great, but without checking the curve, you are flying blind. So your patient also again then. So you need to be very clear and put this thing in place. So next, in the lab detect framework, L for linearity, A for antibody testing. So this we have already discussed in our cases also. How does this antibody steps in, and it's non-negotiable, certainly in lean adults, wherever you have a history of the drug not responding, or if there is autoimmune history. So let me just classify it like, the GAD catches about 70 to 80% of the latent immune autoimmune diabetes. IA2 will add another 15%, and ZNTA will increase the total sensitivity to up to 92%. So if you have a reflex panel which can be done easily within 24 hours, you can make it an routine, and you can ask the patient whatever your lab protocol says, and you can very well go ahead and detect this at very early level, because a single antibody justifies early insulin, and it will avoid all the unnecessarily medication in this case. Also, always keep your mind open, go ahead with the thyroid and B12 screening alongside, and you can add in your LIS commands also. So you can prevent any mislabels also, all these. Now, in the lab detect framework, the B stands for brain versus pancreas. Now, this is again, there are two hidden engines of dysglycemia. Now, in the type 3, where is where the diabetes get truly deceptive. Now, when we talk about two patients, having same fasting glucose, say 160, one has dead pancreas, another has hungry brain. So if C-peptide is low and fecal elastase is low, you are looking at type C, maybe possibly pancreatic failure. And if C-peptide is normal, yet glucose is climbing, then you need to think, you need to speak to clinician. There's likelihood patient may be throwing some cognitive, thing. There's a cognitive screen also, which I've not seen anywhere actually, but they say you can give it to the phlebotomist and he can record it. I wonder how will we do, but that is one thing which can deal with something related to the pre-Alzheimer's disease, that is the cognitive type 3 diabetes. So the three reflex testing most important here when we have brain versus pancreas situation: C-peptide, fecal elastase, and a simple cognitive screen. I don't know how many of will be able to do at the phlebotomy, but yes, C-peptide and fecal elastase definitely can help. For the pancreatic path, because the therapy will diversely be very different. For the pancreas, it will be PERT therapy with the insulin. For the brain, it may be maybe oral drugs along with the cognition workup you have to do, and then accordingly refer to the neurologist and start the therapy. So think about the brain and think about the pancreas. Don't miss. There is that is the hippocampal insulin resistance, which is actually living probably with this kind of a stuff. Now we move ahead with another D, that is lab detect. So D for detect. So detecting variant, we spoke about this again in our first case. Let's be blunt that HbA1c can lie, and it does. It quietly but dangerous, maybe up to 1 in maybe 100 Indian patients. Okay, so that's why so D is very important to detect the variant. The most important, the red flag is very simple. If A1C is not, A1C derived EAG and the plasma glucose, the value is differing more than 15 milligram per deciliter, the reflex trigger has to go. That is where you have to rerun with boronate affinity cartridge or the HPLC variant. Now, in that also, someone will ask, why not go ahead with the straight away with the full variant? So why only boronate affinity? So in that is a very quick test you can run. That is one thing. And also we can go ahead with the other thing because there's likelihood with the boronate affinity HbE can be missed possibly. So that is another thing we need to think about all this. Uh, the HPLC with capillary electrophoresis variant, that is what you can go ahead. And then when reporting, you should clearly bring it out and in your LIS reporting. Here in your chart, you can see all the reasons I have put and the percentage bias which all these variants can bring in the HbA1c values. So just a small test, but a big, turnover. Now, in the lab detect, we also talk about the end organ modifiers. Very important, we know. So even if there is a no variant, so HbA1c can still mislead. So that's because of the organ level interference. The two most important organ, the kidney and the blood. Okay. So the kidney disease, anemia, and the altered RBC lifespan. So in patient with EGFR less than 30 ml per minute, and patient who are also on erythropoietin, or if there is any evidence of hemolysis or iron deficiency, so HbA1c can shift in either direction from 0.3 to 1%. Okay, so what we need to auto bundle here in this case. So we also learned in our PG days, our instructors and teachers, they always guide us, no, you correlate with CBC, you go and see the creatinine. So this is all integrated. So that's the, auto bundling with the CBC and, creatinine EGFR with every A1C. It will, if any of the following is applied, like what the situation I told, whatever is written here, if patient is on dialysis and all these things, so then you should start thinking on that level. So quick reference impact, like if there is iron deficiency, the A1C will falsely be high. Okay, then CKD stage 4 or 5, it will be falsely low. And if there is a recent transfusion also, A1C is useless for almost close to 3 months because that's the normal RBC turnover time. So what you can do in this case, you can do glycated albumin that can fill this gap. So within a 2-week average, the unaffected RBC kinetics can be seen. So remember, HbA1c is not a glucose test, it's a hemoglobin test. That's what you need to remember. And it is influenced by organs. As biochemists, we are the only ones who can tell which number is lying. The clinicians may not be able to tell. Now, in the lab detect framework, we reach T, first T. So this is T stands for therapy. Now, very fancy drugs are coming in markets. You all know very well that, something very much for weight loss people are taking, even if they don't have diabetes, like Ozempic, and then we have, Mounjaro, all these fancy drugs, GLP-1 receptor agonist and dual agonist, tirzepatide. So ADA is also recommended, what lab monitoring if, catches trouble early. What is supposed to be done if any patient is on these drugs? So let's shift our gear from diagnosis to the therapy safety. Okay, with the rise of these drugs, what we need to monitor is the renal function, most important. So GFR has to be more than 45 mils. Okay, especially with if it is the dual agonist, this thing. Then you do the mini 6 analyte panel, which is very important, in which the pancreatic markers are present like amylase, lipase. The baseline has to be done first before you start the therapy, and then monitoring for the 3 months. The cutoff value is 3 times more than the upper normal limit. That is the lipase spike. Or sometimes the patient will come with the abdominal pain, and we are thinking only, oh, lipase is raised and it is pancreatitis. This likelihood it may be drug related also. Okay, so and also go ahead with the liver function. Though there are very rare cases which have been mentioned, like cholestatic hepatitis, but still keeping a watch, especially with the weight loss, it's very important. It's a red flag. ALP more than 2 times the upper normal limit, along with the weight loss of more than 1.5 kg per week is a big red flag. That is one thing. And then go ahead with the thyroid, especially if there is any nodule or is there any goiter existing, or if there is any symptom also. So the 6 analyte panel, it will just cost very less, 5 ml of blood, but it can catch any of the symptom before it begins. So as a you can always speak to the clinician and you can talk all that such recommendations can be given to the patients. Now moving ahead with in the lab detect framework is the E, that is the exocrine endocrine crosstalk, wherein we spot the pancreatic exocrine insufficiencies in diabetes. So if we zoom back into the pancreas, it's a dual life, okay? So we talked about insulin, but many diabetics, they suffer because of the exocrine pancreas is silently collapsing behind the scenes. So 8 to 12% of type 2 diabetes and up to 30% in type 1 in India have pancreatic exocrine insufficiency. Okay, and it goes unnoticed most of the time. So simple fecal elastase test can bring this, and it can help you. So what happens when fecal elastase is low? So the HbA1c starts creeping despite the therapy, and there will be a patient will also be exhibiting a lot of weight loss. There will be symptoms like greasy stools. They may remain missed also. Patient may not tell also. So because the management will be entirely different, they have to be put on the pancreatic enzyme therapy, replacement therapy with the lipase. So reassessing HbA1c, which after you start the therapy, then you reassess it, you will find it may be controlled, and also monitor the vitamins. So pancreas don't just make insulin, it modulates the drug absorption, nutrient triggers, and glucose response. And only we in the lab can detect the full picture. That's what I presume. Now coming on to another C in the lab detect framework, the continuous metrics, especially this CGM, it is coming into a big picture these days. So how does this CGM, that time in range versus the laboratory benchmarks, how it is different? Now we see this, we bring lived patient experience into our diagnostic equation. So here we see the patient, HbA1c giving us a 3 months value. We all know. So it hides very important things like episodes of hypoglycemia, or any variability of hyperglycemia which is happening with the patient. So HbA1c is just taking 3 month ka span from based on the hemoglobin from the RBC, while daily fluctuation is maybe very different. Okay, now you see this heat map. If you see, so you see the TIR, how it is correlating with the 7% here. You see the 70% is linked with the if someone has 70% TIR, that is time in range, the 70% of the day is spent between 70 to 180 milligram diameter of glucose. It means their sugar is maintaining between that 70% of the time. Okay, it means the mean glucose should be around 154. So if it is 154, the HbA1c should be around 7%. Okay, as per our calculation. But the catch is, the two patients may both have 7% HbA1c, but one will spend 3 hours a day in hypoglycemia, while the other will have a stable glucose. Okay, that is where this is TIR will add depth in your diagnosis. Now what does ADA say? So ADA say we need to aim of TIR more than 70%. It also says that keep the time less than 1% for 54 milligram, means hypoglycemic episodes should be less than 1%. And also it says the the time of hyperglycemia more than 250 milligram should also be less than 5%. So this is the 3 criteria. So today if we pair A1C with TIR, so whenever you have HbA1c which may be unreliable, especially in cases of CKD, anemia, even pregnancies where we are using glycated albumin for long term, you can use TIR for this CGM for decision making. That will give you a lot of information and depth. So this is what I wanted to bring. Now once we have this, it will give you a more clear picture that how to tackle with the hypoglycemic episodes, because HbA1c will not tell you. Now last T in my lab detect framework is the time critical pre-analytics. So when we say beating glycolysis, it's even more difficult. We are introducing AI and all these things in our, but for as a biochemist, for us, beating the glycolysis is a big challenge itself. And when we talk about this, we need to speak about most important thing, the things that go wrong before the sample even hits the analyzer. So most important thing is at 25 degree, the glucose drop is close to 1.5 every 10 minutes. So the sample has to be, so in 30 minutes, GDM diagnosis can slip away. You can see. So that is why ADA says use citrate buffer tubes if your time to the analyzer is more than 30 minutes. And it's better, they say, spin samples within 30 minutes. That's also one of the things. And another thing is, if you know that it is more than 30 minutes, you can even use citrate. You place the sample on the ice, and all the critical samples, especially who requires the NICU hypoglycemia, and other analytes like the plasma lactate and ammonia. So all these things are very important. And when we pre-label the time points, especially in OGTT sample, and we use the citrate, in your lab, what you can do is, like for OGTT, you can make a thumb rule that you pre-label the sample first, and if it is not pre-label, if it is not citrate tube, and if it is the time which he has put and when you're receiving it, if it is more than 45 minutes of delay, it's better to reject that sample because you will not give the correct report. Okay. So most important thing is every 10 minutes the 1.5 mg lost, and then again chances of missing diagnosis, delaying treatment, and especially in GDM, if you ask me, compromise baby probably. And this is how where we beat the glycolysis, and we put this framework in our. So finally I conclude, just summing up. So every tube tells a story. So you can very well deploy this lab detect in in your own setup, in your own way with innovation, linearity, trusting the curve first and doing it every Saturday. You can use with the spare reagents, autoantibodies panel based on the profile, brain versus pancreas, picking what to do, especially the low C-peptide and the fecal elastase, then detecting the variant in case of discrepancy when HbA1c is not matching the glucose values. If there is end organ involvement, you already have a picture, then what to do, what test to employ, and looking for the exocrine link especially, and continuous metrics. When we talk about pairing, we want to know the depth, especially ruling out the hypoglycemic episodes in patients, and then definitely curbing down to get the continuous metrics. When we talk about pre-analytics, that's a 30-minute rule. That's very important. And finally, just towards the end, last two slides for me, just this is something which it is still under clinical validation. So this is a high throughput autoantibody-on-a-chip panel that can screen 100 samples in a microfluid. The details I put it on the screen. So the screening no longer will be limited by cost or the batch size. So this is something which I thought I can bring it here. And then another thing is this MALDI Plasma Fingerprinting with 10,000 ion in 30 seconds. I mean, one spectral selfie of inflammation, insulin resistance, combination of everything, and beta cell distress. That is also again under clinical validation. And finally, if we can deploy something, the AI-powered lab dashboards in our system, where we can have, the live sigma alerts and QC alerts, even before our chart goes for haywire. That is very important. And when we talk about this, it can even go ahead. Our model can even support the delta check, and just with one prompt in place, it can embed the clause for you that this is the clause it is violating, it is the CLSI it is violating. And if you integrate it with your LIS, you'll get the entire report on your dashboard. What will happen with this? You'll save a lot of money in this. Imagine a 20% reagent wastage reduction, and 25% turnaround time will be faster. Not just that, even if you reach the sigma level, you can even go ahead and save the QC cost also. So one glass wall that turns QC from reactive to predictive and proves it in rupees saved. That's for the day. So just closing my today's talk. So to every biochemist here, remember this, that the HbA1c may be 6.8 or glucose may be 92. The chart may be confusing, but inside the test tube there's a full diagnosis. Okay, so if you know where to look, you deploy this framework, you can modify it and use your own training with the AI and use your clinician imagination, the biochemist brain. I think you can make one. Thank you for listening. And thank you very much.
Thank you, Arvind. It was really a very, very interesting talk, and I think all our participants must have really benefited from this talk. In fact, for me, it was really very interesting, especially the cases, how you have built up your session. It was really very interesting.
Thank you very much, ma'am.
Dr. Ashish, can you take the questions from the audience, please?
Yeah. So thank you again, Amandeep sir, for your excellent presentation, sir. Yeah. So I invite the participants to share their questions in the chat, and we can address them. So there is one question from Dr. Veena. Is it okay to use monohydrate glucose for GDT?
Yes, we can use the equivalent variant. These days they come with us in the 83. We see that is already tagged written like that. The 75 gram of glucose, the equivalent is 83.2 grams of monohydrate glucose. We can use that.
Yes. Thank you. There one comment like, shall we get this PowerPoint presentation?
Yeah, I can very well give it to you. That's not a problem. I'll prepare a PDF for this and send it across in the group itself. I hope it will be easy.
So really, the clarity and depth of the topic was like excellent. Really nice.
Sorry, Ashish, I think you can tell the participants that
they
can get video also. We will share it.
Yeah. So this session is recorded. And it will be uploaded on our MB website. Just you need to become a member of that MB website. So you have to just sign up for the website, and once we approve in 3 or 4 days, then you can see the webinars. You can see the MB academic webinars. All the webinars that have been conducted so far, they are recorded and they are already uploaded on our MB academic website. But madam, many times like people are not writing their MB membership number, or they are not the, so this facility is for the MB members only. So if you are not the member of MBI, please be a MB member and you will have all the benefits for MB membership.
So I think we have one question from Dr. Sunil Acha. She has asked how is fecal elastase assessed. So ma'am, fecal elastase is assessed using stool-based ELISA. So that detects the human pancreatic elastase, which is a stable enzyme. Okay? The sample is a small random stool sample, which is what you require for that, and there is no dietary preparation or anything required for this test. And it is a quantitative ELISA test using monoclonal antibodies to human pancreatic elastase. So this is what is the information, and reference range I have already spoken that how to interpret that. That's more than 200 microgram per gram for normal exocrine pancreatic function, for 100 to 200 mild to moderate exocrine insufficiency, and less than 100 is severe exocrine insufficiency. So I hope I answered your question.
Yeah, in fact, fecal elastase we are doing by stochastic also. So now that is also available. You have certain columns where you can centrifuge the stool and get the circulating, and in that fecal elastase spectrophotometric is also available. We are doing it on our
the only, I think, the precaution which you need to be very careful is where it may not be useful is like it can be falsely low if the patient is experiencing diarrhea. that is, that is sample dilution. So just you need to ask the patient before ask that. And best part is even if you give the therapy, this elastic doesn't get affected with the supplementation also.
And sir, do you recommend turbidimetric HbA1c method over HPLC method? Doctor?
Actually, we did this turbidimetric versus HPLC. There is hardly I did my own research project in my lab only 2 years back. So equal variation is very less. It is very less. But yes, since the ADA recommends HPLC, maybe because the turbidimetric method may miss out, and it will give false values in case of any other thing, it's better to go ahead and reset with the HPLC. That's what is the thing. So rate of glucose decline in cigarette is less than 1 milligram per hour, per deciliter per hour.
Okay. That is the one person was asked the rate of decline of.
Yeah. That will come maybe as MCQ.
For Sir Dr. Viswajit sir has asked, this is about the MB website. So sir, you cannot download the videos, but you can see the videos online because we have kept the video on unlisted mode. So you will be able to see, we have uploaded on the YouTube and keep the link on the MB website. So you may not be able to download it, but you can view at your ease, at your time. I hope I addressed your query, sir. Viswajit. Okay. So are there any questions, because we are running short of time? And I also thank all the participants for their valuable time and active engagement. And special thanks Amandeep sir.
Amandeep, thank you once again.
Thank you, ma'am.
Thank you, Shivani ma'am. Yes.
Signing in. Good night, everyone. I think we can sign off now.
Yeah, I
So
think
only that we can address that question. Like, do you recommend autoantibody panel for every newly diagnosed diabetes patient?
No. I told you, Dr. Gaurav, I mentioned that, when you go ahead for antibody, it's not recommended that every newly diagnosed DM should have. I told you the criteria. So the criteria says that for an autoantibody, you have to have a BMI. Okay, that is lean. I said lean, non-obese type 2 diabetes, wherein you have a certain situation, that is where you mention that the LADA should be suspected, the one who is not responding to the oral therapy, okay, and or someone who is also having the autoimmune history in any of the family. That is again one clinical indicator. Then lean person, age less than 50. All these things are you need to take care. Not everyone. It is not recommended to go ahead and do these. So adult less than 50 years of age, BMI should be 30, and there should be rapid, oral drug failures, wherein you need to question this.
Thank you. So all these tests are like autoantibody panels are ELISA based or they are chemiluminescence based? That ZN, T8 and AI.
Both are available actually. Chemiluminescence is also mostly, but we need to see what we can afford. As a patient also can afford.
Yeah. So with this, madam, can we conclude it? Like, can you view?
Thank you so much. Thank you, Dr. Amandeep, once again. Good night, everyone. Thank you for joining.
Yeah. Okay. Thank you. Bye all. Bye. Have a good day.